The IVC is a simple structure. It's a vein. There's not much structures to identify, but finding it, if you're not systematic or if you move too fast, might be difficult. Let's take our probe, indicator towards the patient's head, and palpate his rib cage. As I palpate up and go to the exact foot process, I go back just a millimeter or two, and that's usually in that area we'll find the IVC. So now I was lucky, I was already on it, but if you palpate the rib cage and do this, you'll often be at the right spot from the start. Now when we see the IVC over here, if it seems kind of short on the screen, now that's still the IVC, but it seems kind of short, doesn't extend on its whole length from side to side on the screen, that's because you're not perfectly in long axis. You're not perfectly in line with the IVC. So you need to do some rotations until you actually see the IVC get longer on the screen. And as I rotate, now it's small, I'm rotating, it's getting longer on the screen. And there you go, you get the IVC. Then I will tilt to go from side to side until I see the biggest diameter of the IVC. That's how I know I'm midline, that I evaluate the IVC at its biggest. If you look right here, there's a bit of gas in this zone. If I were to go down progressively towards the patient's feet, it would get worse. At some point, I would lose the IVC. I would not see anything on the screen. So whenever you find the IVC, it looks kind of okay. Just try to track it up, follow it until you get on the patient's liver. And you'll get on the patient's liver usually just before you go over that lower rib. So I'll keep on moving higher up and see now there's only liver in the near field. There's no air, there's no bowel, there's nothing that impairs my ability to get the image of the IVC. I know that's the IVC because it goes in the right atrium, it joins the right atrium, I can see that, and because I see the hepatic vein right here. We'll assess size and variability of the IVC just before the hepatic vein, so a few centimeters away from its junction with the right atrium. Now look what happens if I tilt the probe slightly and look more medially. I see something right there that kind of looks like the IVC. But this tubular structure over here is the aorta. Sometimes it's very sharp on the screen and you might be really, it's easy to mistake it for the IVC. Now, if I get a good view of the aorta, it's nice on the screen, it's very long, that's half bad because you know you're in the right plane of cut, except you're too medial. So just slide or tilt your probe to look a little bit more on the patient's right, and there you go, you are on the IVC. Now that's a technique I would use if I was going to see the IVC from the get-go, but if I'm, just put a bit more gel, I'm already doing a subcostal view, so let's do a subcostal right here. So I get my image, and just take a deep breath please. And I have the right atrium over here. I know that the IVC will join the right atrium, so I can take advantage of that information and slowly turn counterclockwise my probe until I see a structure that takes off from the right atrium. When I see it, I can lift or rock my probe so that I center the image right there. Now, as I'm doing this, I kind of feel my shoulder going up and twisting. So if we go back, what I can do instead of turning my whole arm is actually just to turn the probe with my fingers. I'll just find the view again. There we go. I'll turn with my fingers, and as I turn my fingers around the probe, I find the IVC right here, rock to center this in the center of the screen, and then I do my usual adjustments, rotation and tilting, to find the longest IVC and to see it midline.